Good morning, good morning, good morning. Uh, my name is Joel Johnson, and I have the honor of serving as the President and CEO of TASK, Treatment Alternatives for Safe Communities. And we're all glad that you could be with us today for this great and important topic. TASK is a part of the Justice Community Opioid Innovation Network, or JCOIN. And JCOIN works to ensure quality care is provided to individuals with opioid use disorders in justice settings. While there have been substantial increases in the number of jails and prisons providing medications to treat opioid use disorder, the resources and the associated costs can vary widely from state to state and jurisdiction to jurisdiction. And so our webinar today will discuss new customizable tools developed by researchers at Weill Cornell Medicine that helps us with identifying an optimal medication delivery model based on existing resources and costs that would be required to implement and sustain a model at respective facilities. So we're really excited to have this discussion today. So I'm going to introduce a few people to you, and we could get this webinar underway. And first, I'd like to start with Dr. Tisha Wiley, and she can bring us a few comments. Dr. Wiley is the branch chief and associate director for justice systems at NIDA. She provides leadership across NIDA on justice-related issues. During her time with NIH, Dr. Wiley has developed and led dozens of initiatives across a wide range of topics, including justice, juvenile justice transformational interventions for adolescents in the legal system, and criminal justice drug abuse treatment studies, cooperative research programs. So we'd like to have a few comments from Dr. Wiley at this time.
Thank you so much, Joel, and welcome everyone. We're really excited to have you join. As Joel mentioned, JCOIN has a mission of reimagining the way that we respond to addiction and overdose within criminal legal settings. And really the core of what we do is about bringing together researchers, practitioners, to work together and practitioners across both justice and community-based settings to work closely together to come up with solutions to address these issues. And the guiding vision for everything that we do in JCOIN is the idea that every individual who's involved in the justice system should have access to effective treatment. And that's something that's true whether they're detained or they're out in the community. One of the core things that we want to do in the way that we work, or a couple of the core things we want to do in the way that we work in JCOIN is really build these close relationships between researchers and practitioners. But also to build some feedback loops between research and practice so that we're conducting research that's practical and useful to the field. And I'm really excited today to have Dr. Murphy and Dr. Ryan here today to share their work that they've done. And this is, as I'll describe to you, for me, it represents sort of the best of what we can do in JCOIN. It's a collaboration. They work across many JCOIN projects, but the development of this tool really grew out of a close relationship with some of the practitioners in the field. And so I think now they've published a paper on it. They've got a really great tool that you can go online and access. And in turn, hopefully that'll turn into more research questions and create that cycle of science to research and creating feedback loops to create solutions that are useful to the field now, not 5, 10, 15 years from now. So I hope I'm going to get out of the way so you can hear their great content, but really just excited to be able to share with you this amazing tool and this work that they've done. I want to make a plug. They'll give you a lot of resources, but I know the team will put in the chat JCOIN-CTC.org, which is where you can find all of our resources, which include a number of courses and other tools, and just the way that we strive to create this process of sharing information back. And you can sign up for our newsletter. So I just want to encourage you, please use those resources. And if there are other resources that you see a need for in the field, or questions that are burning questions from your perspective, please let us know what those are so that we can continue to evolve JCOIN to be responsive to the needs in the field. So thank you for the opportunity to introduce JCOIN and this project, and how excited we are about this effort. And with that, I will return it back to Joel.
Thank you, Dr. Wiley. Appreciate that, and thanks for introducing JCOIN. So again, we have an interesting topic today, and I have two speakers. A little housekeeping. We'll disseminate information in the chat, but if you have questions, please put those in the Q&A box. That will allow us to better track them and hopefully get your questions answered in a timely manner before the webinar ends. So first, let me introduce Dr. Sean Murphy. He's the Associate Professor of Population Health Sciences at Weill Cornell Medical College. He's a leading expert on comparative economic and effectiveness evaluations of substance use disorder interventions alongside clinical trials and cohort studies in multiple settings, including criminal justice, primary care, substance use treatment, and harm reduction facilities. Dr. Murphy is a health economist and econometrician by training, and his primary area of expertise pertains to the management of substance use disorders and related conditions. Danielle Ryan is a senior research coordinator also at Weill Medical College. Danielle provides research support to NIH-funded studies on interventions to treat opioid use disorders. She works on economic evaluations on the Justice Community Opioid Innovation Network Initiative and HEAL Community Studies. Dr. Murphy and Ms. Ryan, I'll turn it over to you.
Great. Let me share my slides. Thank you so much for the introduction, Joel and Tisha. And I also want to just thank the task and the CTC and NIDA overall. We're very excited to be here and have the opportunity to share this information with you. And hopefully you'll find it of use, and we look forward to discussing any questions at the end. So as Tisha and Joel said, we're here today to really talk about this budget impact tool that we created alongside our work of several clinical trials. So I can just get into that. We already had an introduction of our wonderful presenters. Quickly, just funding declarations. As I mentioned, the research that you'll see here was supported by NIDA through a couple grants, two of JCOIN. One is an R01 of mine, and another is our P30 Center Cherish, which I'll talk a little bit here about in a second. And then just a declaration of interest. So just quickly, Cherish is our NIDA-funded P30 Center, as I mentioned, focused on health economics of substance use and related conditions, primarily HCV and HIV. You can see our director, Dr. Shackman here, and I co-direct the methodology core as well as and I direct the consultation service, which I will tell you a little bit more about here at the end because it ties in nicely with the tool that we'll be presenting. So quick outline, just give you an overview, a little bit of background on why the tool is important, talk about its general purpose, give you some details, and then we'll probably spend a good chunk of time just going through a hypothetical example. We'll talk a little bit, just kind of wrap things up, talk a little bit about the benefits of the tool and how you can access it and get assistance with it and all those good things, and then leave hopefully plenty of time for questions. So quickly, as was mentioned, we've seen quite a large increase in the number of jails and prisons that have begun to offer medications for opioid use disorder, or as you'll see through the presentation, MOUD. I did try to keep the acronyms to a minimum. So the ones you see here pretty much will be the only ones throughout the study or throughout the presentation. Of course, the three FDA-approved medications for opioid use disorder, which is a first-line treatment, are buprenorphine, methadone, naltrexone, and there's multiple formulations. We'll talk about that briefly. Methadone, of course, requires federal certification as an opioid treatment provider, which plays into this decision quite heavily. We know that the resources required to implement MOUD programs in jails and prisons can vary quite a bit just due to the myriad of possible combinations of existing services and potential delivery models. So for example, the facility may not be offering any MOUD at this point, and moving from there to, let's say, offering everything, or perhaps offering MOUD upon release from incarceration, continuing coverage. They may be continuing coverage of those who are entering the facility and converting to offering both induction and maintenance, et cetera. I think you get the idea. Then, of course, delivery models. There's multiple delivery models, including the medication being provided by the facility's healthcare team, some form of vendor-based delivery, whether that's outside of the facility or residing in the facility. And then, of course, a combination of those two, in some form or another. Another thing that we know as criminal legal researchers and people just in this space is that jail prison healthcare it's typically constrained by fixed budgets, unlike civilian healthcare, and often comes from state or federal sources. So it's a fairly rigid budgeting process, right? Which can be problematic, let's say, if you're trying to add additional resources. And of course, uncertainty regarding the resources that would be required to implement and sustain a program, as well as the costs associated with those resources. If there's uncertainty around those, that can be a significant barrier to adoption, especially within a strict budgetary framework. So we developed this customizable budget impact tool to assist jail and prison stakeholders and criminal legal researchers in estimating the costs associated with that implementation and sustainment of a chosen MOUD program. In order to inform the tool, we completed site-specific microcosting analyses in great detail as part of our work alongside the 3 different clinical trials that I mentioned before, that were all 3 of which were evaluating the comparative effectiveness of various MOUD models for jails and prisons. So quickly, for those who are not familiar with microcosting, essentially it entailed systematically capturing, cataloging, and valuing changes in resources that resulted from the intervention. Now, one thing to keep in mind, as you'll see as we go through, especially through the hypothetical example, is when we do this and when we really focus on capturing all the resources that are required, we want to account for those that make up both accounting costs and economic costs. So accounting costs, right, those are the actual expenditures of all resources that are used by the program. Whereas economic costs include those accounting costs, but you also account for opportunity costs. So essentially anything that you may not be paying for directly, but you're getting those resources, you're utilizing them. So for example, donated services, volunteer effort, subsidized rent, et cetera. And this can even be within the facility. You're borrowing somebody who would typically be doing this particular task, and you're moving them over here. And the reason we want to do that is to make sure that we're capturing everything really that would be required. So let's say you were to take this and start it brand new somewhere else, another facility might not have access to those same donated services, or have the same ability to, say, move things around. So the point being, you want to make sure and capture those, and especially if you're going to be creating a budget for let's say an external funder, right? You want to really be able to account for all of those things. So to do this, to do the microcosting, we utilized a combination of administrative data and then data collected by semi-structured interviews of relevant personnel. So we went on site visits to all of these facilities, and then had the opportunity to interview and just learn from the individuals actually working in these facilities and providing this care and all of those good things. When I say relevant personnel, of course, I mean those that are most familiar with the day-to-day operations of the program. So we spoke with clinicians, social workers, managers and directors, IT staff, administrators, counselors, you name it. And everybody was extremely helpful, and we are very much appreciative. So the studies, the sites, so there were 7 jails in Massachusetts as part of the Massachusetts JCOIN site that we went to. 6 jails in Maryland as part of the JCOIN Friends Research Institute. And then 2 prisons in Maryland and Pennsylvania as part of my R01 that, again, is also focused on MOUD in jails and prisons. So this, you can see the link at the bottom, but this is from one of the resources. I'll give you a few more later in case you're interested. But that help provide some guidance in terms of what different model structures there are and kind of how those might be set up, right? Which then in turn we can, the budget impact tool can be used alongside of that to really help estimate the costs associated with those resources and look at, say, costs associated with different models. But you can see these can range quite a bit from offsite medication administration, on-site medication administration by an external provider, so on and so forth. And so I'm not going to go through all these right now. Like I said, there's resources for that. But what I'm going to focus on primarily are the three categories of MOUD delivery models that we observed. And so these are, somewhat broad categories, but capture everything pretty well, I feel like. So the first being having an outside OTP certified vendor who provides and administers methadone on site, and then say facility clinicians provide and administer the BUP and the naltrexone, given that there's fewer regulations around those. A second model we observed was an OTP certified vendor who actually works inside the facility. So a dispensary is created for them. The vendor provides and administers methadone and BUP, and the facility then may or may not administer naltrexone. The vendor is also able to do that, of course. The third is the facility decides to become their own certified OTP. They create the dispensary, administer all three forms of MOUD, and really, like I said, just kind of keep everything in-house. So just some benefits and trade-offs that we'll talk about with regard to the three models. So you have the outside vendor who provides and administers methadone. The nice thing is if that vendor is local, right, which you would assume they would be, if they're a local OTP, that helps ensure medication continuity for methadone at least, and hopefully any other medication that they provide. So when individuals re-enter the community, correctional facility partnered with vendors, licenses, accreditation. So you don't really have to worry about any of those things. The vendor takes care of that. Same thing with, say, discharge planning or other services. There's kind of a host of services that the vendor can offer, depending on if you want them or not. Trade-offs, of course, there's the additional cost associated with the vendor. There's going to be meetings and trainings with the vendor and the staff to make sure everything's coordinated, including, say, administering dosing for individuals who are incarcerated and have other obligations. So kind of adds that extra coordination component, if you will. The second model, where the vendor works inside the correctional facility, the dispenser is created, and the vendor administers medications. Again, you've got some of those same benefits from before, largely. The correctional facility is able to work under the vendor's licenses, accreditation, and again, the vendor's kind of right there on site. They can provide other services that are important, for example, discharge planning, counseling, intake, some of those components. And again, you have many of the same costs, availability of the vendor, staffing to provide facility needs. You have possibility of turnover, things like that have to be taken into consideration that are not completely within your control. And then you still are likely going to need to require or provide, say, additional correctional staff time for dosing and things like that. And then finally, the correctional facility creating their own OTP. So it benefits in terms of just timing for dosing incarcerated individuals, less effort required to coordinate that time. It will utilize your own staff and just kind of keep everything in-house. Lots of nice benefits associated with that. And of course, there's some trade-offs as well in terms of finding and reconstructing space for the dispensary, the cost of the dispensary, additional staff you may need to bring on board, and then just time for licensing and accreditation with regulatory agencies. There's quite a bit, especially in terms of upfront costs, but of course the downstream costs are likely smaller. So this is just a page with additional resources that I mentioned with, just from lots of good places in terms of just providing ideas, evidence, and what have you of these different models and how to really kind of things to consider, I guess I should say, to get one of these models up and running. As Tisha mentioned, the tool that we're going to be looking at has been published. It's open access. You can see Danielle is the lead author, and our other co-authors who were extremely pivotal in just creating this tool, especially say, Sheriff Katusian, Cash Siddiqui, and Ed Hayes were really kind of our partners on the ground that were just enormously helpful in getting this done and just making sure that it does what we want it to do. So quickly, when you look at the tool, you'll see that we've got things categorized a number of different ways. So the first thing is that the resources and their costs are going to fit into one of these, either fixed, time dependent, or variable. And so fixed resources costs are those that are incurred only once, so during startup, and they're not directly related to the number of participants. So just kind of those infrastructure or whatever, those pieces that you need to get things going. Time dependent resources and those costs, these are recurring, so recurring costs, but they are fixed over a given time period. Not that it's particularly relevant here, but I think a really easy example is, say, a lease. You want to provide some kind of service, you're going to need a space to do it in, regardless of whether you have clients coming in, and you're going to have to pay that every month that you want to be in business, right? And then, of course, variable resources and costs, which are a direct function of the number of participants. So this could be medication, staff time, anything that's really going to, I should say, for dispensing the meds, but anything that's going to vary and need to be expanded as the number of patients expands. Once we have the resources categorized as the fixed, time dependent, and variable, we then add them up essentially within two different phases. So we have our implementation phase, which consists of costs incurred for the purpose of startup, and then over the time period required for this facility to hit what we call a steady state with regard to the intervention. So essentially that steady state being the point where the kinks have been worked out and you feel like the resources you're using now, especially on a per patient basis, are going to be fairly steady going forward. So this implementation phase then, of course, is going to include those fixed costs that I talked about, as well as the time dependent and the variable costs that are incurred over some initial time period. So in the tool, you'll see we initially have it set up as a 12-month time period. So assuming you would spread those fixed costs out over the course of that first year. But of course, that's something that can be adjusted if you want to change that assumption. And then the sustainment costs, as I mentioned, those that are required to continuously operate the intervention over time. And this would then include the time dependent and variable costs on their own after you've hit that steady state. So as far as unit costs, so we used what we call a resource costing method, and meaning that our primary objective was to capture resources, right? And units of resources, how many are needed, et cetera, including labor, supplies, you name it, right? And then we assign nationally representative values to them, which are currently in 2020 US dollars. And I should mention that the tool, being that it's live and it's free on the freely available on the Cherish website, it's also something that we plan to continue to update. In fact, I believe we even have a couple things in the one that's presented here that we'll be updating and putting on the website. A couple things that are not in the tool currently, I should say. But just quickly, hours and wages. So those were derived from the Bureau of Labor Statistics. Medication and supply costs are from the VA Federal Supply Schedule. Travel expenses, we use federal reimbursement rates. And then for contracted vendor fees, we basically just estimated an average across multiple facilities. So things that we observed. So none of these reflect the exact cost used by any given facility. But the nice thing, again, the tool is very customizable. So this is just kind of to start. If you want to change any of these for costs that are more relevant to your particular facility, that's easily done. So just wanted to give you a quick idea of the different resources and costs that we currently have in the model. And of course, as we learn of additional resources that are relevant, those will be added as well as their cost. But you can see multiple things for technology, clinical supplies, miscellaneous, anything right down to the crackers and cups that you might need for the buprenorphine dosing, storage, and we'll talk about some of the uses of those, and any potential IP services. So of course, like I said, these are all just options that can be selected. They're not automatically in any given delivery model. So medications, methadone, bup or bup with naloxone, and naltrexone, and you can see the different forms. These are also all in the tool with associated costs. Little information as far as what you must have in order to prescribe or administer any of those given medications. Here's just a quick screenshot of the different medications and dosing that are in the tool at the moment. Okay, so the tool itself, it's a Microsoft Excel worksheet. So, again, something many people are familiar with and making it relatively easy to use. And it has a lot of drop-down menus built in to kind of make it even more user-friendly. And then it consists of these 5 worksheets, the dashboard, a fixed and time-dependent cost. So this is kind of where you go in and enter the different resources that if you need to adjust any of those or enter how many you need. Same thing with the therapy costs, labor costs, and testing supplies. So really all of those bottom 4 sheets feed into the dashboard, which of course does what a dashboard is supposed to do and gives you a nice summary of those different components. So this is just a screenshot of the dashboard. You can see that it's got the 3 different primary categories that we talked about: the fixed, startup, the time dependent, the variable costs, and then the year 1 cost, so essentially your implementation cost, the subsequent annual cost being the sustainment cost that we talked about, and then the sustainment per patient cost. So there's also a place to enter in the number of patients that you think you'll have, including the number of inductions, number of just maintenance, etc. So, so given our fixed costs, you can see just a little pop out on the right of the spreadsheet that incorporates those different components. You may not see every single thing on there just for reasons of space, so we could present it. But as you can see, you can go in and you would enter, let's say there's a vendor startup fee, how much that is, provisional OTP license. So this would allow, where the facility has, say, up to a year to become accredited, they can get this provisional license. That also allows them the opportunity to start the lengthy process of becoming an OTP if that's something that they want to do, which is where you can account for that time. Of course, regulatory agency inspections, dispensary. Again, if you're going to, say, carve out a new space, if you're going to require furniture, supplies, construction, components, supplies that might be needed, if you're going to become your own OTP, such as a safe to house the methadone and other meds, things like that. So anyway, you get an idea of kind of how this works. And again, then that feeds into the tool itself. Time-dependent costs include, again, anything that is going to be reoccurring and you're going to be kind of consistently accruing this cost, but is not necessarily related to the number of patients that you see. And of course, if some of these that are in there now are not particularly relevant in your case, you ignore them. Or if you feel, let's say, that they're not necessarily a time-dependent cost, maybe it's more variable, also something we could move if need be. But at any rate, get an idea of kind of what that looks like. And then, of course, our variable costs. And as you can see here, say with the employees, you can choose kind of who your clinician is going to be. So let's say you choose a physician. We've got, like I said, the national representative salaries and fringe rates in there, as well as the ability to enter in the amount of FTE that you expect this individual to require for the program. Also the testing, assuming that's going to be done kind of on a per patient basis, varying over time, and any additional supplies, like I said, including the crackers, cups, you name it. So it really, we try to basically incorporate everything that might be required. Additional things here with the variable costs. You can see here's the OUD treatment, medications, the different types, what that daily cost is per patient. So, whether that's something that the vendor's charging or a price that you're paying on your own. Again, you can work in how many patients you expect to have on each one of these per month, average number of days, and then of course months. So everything's kind of built to become annualized at the end, right, in the dashboard. And again, like I said, you can determine in terms of number of patients that you expect, how many do you expect to be inducing in a given month versus maintaining. That's all very customizable. Right down to the counseling, group, individual, you name it. Okay, so I think we're doing pretty good on time. And so now I want to spend some time just going through this hypothetical example. Like I said, keep in mind, this doesn't reflect any particular facility. It's just an example we came up with to show how the tool works. And so, of course, it includes both the accounting costs and the opportunity costs that we talked about a little bit ago. So in this example, we're assuming that the vendor provides both induction and maintenance on bup and methadone, while extended release naltrexone is offered by the facility. And we are assuming that all three medications are going to be administered by the facility staff. And the average number of MOUD patients per month is 123. So we're assuming 86 on bup, 28 on methadone, and 9 on extended release naltrexone, and broken up as such, 42 patients being inducted per month and about 81 patients maintained. So you can see here in the dashboard, just an overall look at kind of what we have. And if we add all of this up, and we'll look at, kind of what's going on behind the background here, but you can see our year one costs come to a little bit over $4.5 million. The annual sustainment cost being just under $4.5 million, and that resulting in a per patient sustainment cost of $3,000.44. Okay, and the reason, again, we focus really on that sustainment per patient is those fixed costs, after that first year or whatever period, they really just become negligible going forward. You hit that steady state, and what you're primarily going to be interested in going forward are those kind of annual costs that are required to keep the program running. So in terms of our fixed costs here, you can see that we assume the facility required the installation of new software by ITS to input confidential data regarding dosing and assessments, and we assume a fee of $10,000 to get that done. Storage supplies were purchased for when the medication is retrieved from the OTP to safely deliver the methadone and buprenorphine to the jail or prison. And storage supplies consisted of lockbox, construction totes, and came to a total of just over $5,000. We also assume that the facility and vendor employees met weekly for an hour for 8 months prior to the launch of the MOUD program to discuss things like program logistics, policies, procedures. In addition to that, we assumed an 8-hour startup training was done for the facility's healthcare staff, which included a registered nurse, manager, an LPN, and an RN, as well as a 2-hour office-based addiction treatment training for both nurses and supervisors to attend. And we can jump to the time-dependent costs. So in terms of our time-dependent costs, components included an annual licensing fee, the annual software system, annual trainings, weekly and monthly meetings. We did include all the personnel here, just again for space, but they're in the cost. And medication delivery, as well as the dosing process. So we assume that the vendor charges the facility an annual fee to cover licensing and other requirements necessary to provide OTP services, as well as a monthly administrative fee to oversee the program. And that came to a total of $74,000, just over $74,000 per year. The software system has a per user cost of $112, and we assume 10 users for an annual cost of $13,440. We further assume that the facility and vendor employees are required to attend an annual 40-hour training that provides an overview of employee responsibilities in the context of the MOUD program and MOUD education. Additionally, a multidisciplinary team meeting is held weekly to review patients' treatment strategies. Weekly meetings also occur between the vendor's managers and facility staff to discuss day-to-day operational issues, reviewing program concerns, etc. Monthly meetings also took place with the facility and vendor nursing staff to discuss any concerns of the MOUD program process. So for example, say avoiding diversion. We assume that the OTP is approximately 10 miles from the jail facility. So the staff inform the vendor of all relevant dose information for each medication, which are then stored in secure lock boxes and construction totes and picked up the next morning. To pick up the medication, 2 correctional officers accompany the vendor nurse to retrieve it, and it's then administered, as we mentioned, by the facility's healthcare providers. Following the medication provision, the empty methadone vials are returned to the OTP by 1 correctional officer and a vendor nurse. So accounting for all of that, the total number of miles accrued within a month is 800, resulting in a total annual medication delivery cost of just over $100,000. And the method of trying to ensure the buprenorphine tablet is fully digested to avoid diversion is a bit lengthy and more resource intensive than, as you can see, than compared to, say, methadone or the extended release naltrexone. So that process consists, in our example, of 1 nurse and 2 security officers. It includes the nurse crushing the tablet, placing it under the patient's tongue. They're required to sit and be observed by the security officer for about 15 minutes while the tablet dissolves. They're then given a cup of water to swish in their mouth, followed by a cracker and an additional cup of water to ensure the tablet was fully digested. Dosing, in this case, we assume takes place in groups of approximately 10 people and averages about half an hour per group, resulting in total annual time-dependent costs for the MOUD delivery program of about $543,000. Sorry, I want to go back for a second. Let's see, the testing tab, did I get to that? Oh, here we go. So testing tab contains different types of drug screening tests used for maintenance induction referrals. We assume here that the random urine screens are done throughout each month to ensure compliance during treatment. We also included additional testing supplies, the crackers, the cups, things like that. And you can see the annual cost for those tests, mouth swabs, crackers, cups, came to just under $89,000. Then in terms of our variable costs, so here we have the many different medication formulations, the mean per patient cost for each med, number of patient days, labor costs associated with the different types of visits. So for example, induction versus maintenance, and program counseling for group and or individual counseling. So if we assume a vendor initiated medication cost of about $10 per person per day for oral bup and methadone, and then we can figure out the estimated cost for MOUD maintenance assessment. If we assume that that's $25 per patient, and the induction process is about $205 per patient. So if we assume the average of 123 patients we talked about before, with the 42 inductions and the 81 visits being maintenance per month, the total annual cost of those two things comes to about 103,000 and about 24,000 respectively. We also assume that the facility offered 4 one-hour group therapy sessions per week, which resulted in 16 hours per clinician times 2 clinicians per month, resulting in the total cost of group therapy being about $1,423 per month and just over 17,000 annually. Let's see. So all of this together, we come back and we can see how everything pulled in nicely to our dashboard again. And our implementation costs in this example came, as we mentioned, to just over $4.5 million. And again, we're assuming those fixed costs are being distributed over the first 12 months of the program. And the annual sustainment cost coming in at just under 4.5 and coming down to a per patient cost of just over $3,000. So a couple considerations when doing this is, keep in mind that this example, it's not specific to any particular facility's MOUD program. It just demonstrates one possible use of the tool, of which there are many. So feasible MOUD delivery models, again, they're going to vary based on factors like location, capacity, funding availability, existing personnel. So, hence the reason that we really tried hard to make this tool very customizable and hopefully still fairly user-friendly. And it's also important to keep in mind for decision makers that, in addition to say just the relative program costs, it's also important to consider the relative effectiveness of feasible models, as well as or including potential cost offsets resulting from successful treatments. So some of those downstream cost offsets that you'd hope to see, such as reduced recidivism, lower high-cost healthcare utilization, perhaps decreased reliance on social safety net programs, etc. So the care provided by jails and prisons, as we all know, is critical to fighting disease and promoting both physical and behavioral health. And we also have seen from preliminary research, and have a lot more coming, hopefully, that incorporating MOUD into that care model can promote both public and economic health in addition to the individual's health. The budget impact tool that we presented today is intended to really help inform the decisions, real-world decisions, and it provides practical information on the costs associated with the implementation and sustainment of, really a multitude of MOUD programs that could occur in jails and prisons. As I mentioned, it's customizable, so users can select the quantity of each relevant resource, adjust the unit cost if desired, and be able to view the detailed cost estimates for each resource category. Additionally, the tools and the manuscript are available on the Cherish website, and we have plenty of other resources up there as well that might be of interest to especially, say, criminal legal researchers, but we are continuing to develop and build budget tools that will also be put on this website for really just various interventions that we study, including anything additional in the criminal legal space that comes up. And then I also wanted to make just a quick plug and discuss very quickly the consultation service that I direct as part of Cherish, and the purpose being to support researchers or really anybody else who needs assistance with these things in the design, implementation, interpretation, dissemination, and of course translation of economic evaluations, but also tools such as this that can hopefully help any individual really who is considering, or any facility who's considering a program similar to this. We have a wide range of experts that can assist with that, and the consultation service is free for up to 6 hours, and just requires going to the link that you see here on the Cherish website and answering a few questions, and then we will follow up.